Hello everyone, welcome to this webinar. I hope everybody is able to uh, watch this webinar without much technical problems. Thanks for coming, those who are listening to this webinar. In this webinar, we are going to discuss about acute stroke management. That is, I'm going to tell what's the major problems that are in the acute stroke, and what are the we are going to discuss the problem, that is what is contributing to that problem factors, and what are all the intervention strategies that we are going to we can apply. Before I start, I just want to tell one thing, that most of the information that I provide in this webinar are based upon current evidences, except in the last session where I will be giving some examples of the technique. Those are all the techniques that we are using in our setting, which is based upon functional training. Okay, let's start. In this webinar, we're going to address three issues. That is, first, fundamentally, the problem in acute stroke, that is, patients are mostly inactive and why they're inactive. And second is what kind of exercise or on a broader term, intervention strategies that we should use to make them more active. And thirdly, it's the small part of it, but still I think it's significant, that when to start exercise after acute stroke. So in acute stroke, the major problem that we have to deal with is inactivity. It's a major problem because it affects the patient's recovery. I've given some numbers of statistics, which you can see that 51% of death after stroke has been attributed to the inactivity that is seen after stroke, especially acute stroke. And this inactivity increases their disability. That is 7 times increase in dailies, the disability adjusted life years that they have, it increases. And it increases by contributing to poor long-term outcome, delayed and incomplete recovery. In many times, inactivity during acute stroke contributes to more problems than what we were able to see. So we have done a study to understand this problem in a more detail. So we did a study recently, a year ago, where we have observed patients who are throughout the day. I mean, what they are doing and how they are spending time in an entire day. We observed the patient from morning 8:30 to 6 p.m. Every 10 minutes, we have observed them and noted what activities that they are doing. The result shows that about 90% of the time, see, this time is about between 8:30 to 6 p.m. It doesn't cover their time they spend in the night during sleep and so on. So even in the daytime, about in the 9.5 hours that we have observed that 90% of the time that they are inactive. Inactive in the sense they are either lying on the bed or sitting on the bed. Only 8% of the time that they are spending in any active, uh, being active, which includes standing, walking, and other things. So this is the problem. Now we know that inactivity is causing major problems to their recovery, and at the same time, most patients are inactive. So this is the major problem we are going to discuss in this webinar. I'm not going to get into other aspects of it, such as how will you train upper limb or gait and so on, because that's entirely a different aspects. You need entirely different sessions, even courses to attend to. But this webinar will focus on why they are inactive, what contributes to their inactivity, and what we can do about it. So now we will look into this problem of inactivity a bit deeper. That is, why do patients after acute stroke spending most of their time in simply lying on sitting on the bed? Uh, One major reason is that stroke is a disaster in anyone's life. That one, we all know that it has a sudden onset. That is, one fine day a person finds himself paralyzed on one entire side of the body, and he cannot stand, he cannot walk, and many people have problems in speaking and even eating and so on. So in one day their entire life changes, and that leads to the initial response to that disaster is shock. They're shocked, and there is a fear and anxiety about their recovery, that is whether they will be able to get back to their usual life that they were having, and which also leads to a depression, and their overall mood is very depressed. And that is one of the reason our patients are not moving. They're just simply lying on the bed thinking of all these things, coping with this disaster that happened in their life. And this is one of the reason that why they are inactive. So let's look into what are the other reasons for them for being inactive. The next reason, which is major reason from a physiotherapy point of view, is that poor knowledge about the nature of stroke and its recovery. Here I mean poor knowledge, primarily the poor knowledge of physiotherapists who are treating, and also other healthcare professionals such as nurses and the physician and their family also. That is how recovery takes place. Most of our understanding of recovery after stroke is influenced by Brainstorm's stages of recovery, or some might say even Bobat, but there isn't much difference. We can see everything together. See, in this brainstorm stages of recovery, we were told that after stroke, patients recover in different stages. They follow through the stages of starting from flaccidity and moving towards spasticity and synergistic movement, and eventually they gain control over isolated movements. So this is what has dominated our understanding of how patients are recovering. But if you look at this closely, here the recovery has been explained primarily in terms of changes in muscle tone and the ability to control movement. And also that it shows that the initial stages where there is not much recovery, and this explains as if most of the recovery takes place in the later stages, that is 4, 5 and 6, and the initial there is much less recovery. It is flaccidity, and most of the time we have to deal with flaccidity. So this has dominated our thoughts, and therefore when we go and treat a patient in the early stages, we see that there is flaccidity, and we think that flaccidity is the first stage. So we will wait for the next stage to come where there is some synergy, and we can break the synergy and get movements and so on. Where we accept flaccidity as part of recovery, that is, we accept, in other words, that no activity as part of recovery. And this has dominated our thoughts, and mostly in this during this time we spend most of our time in giving passive movements or some sensory inputs and so on, because we think that there is no recovery during this time, and at this stage of recovery only passive movement and sensory stimulation is the most appropriate treatment. But this idea is outdated, because this explanation of recovery states has been given by Twitchell, and it's used by Brainstorm for our approaches, that it's a very outdated in a sense that in early 1950s they had this kind of understanding, but stroke recovery, or our understanding of stroke recovery, has changed a lot due to advances in neurology and our understanding of how brain functions and other aspects of brain function such as plasticity and so on. So we have to move ourselves away from this understanding of recovery, because this understanding of recovery actually make us contribute to the patient's inactivity, that there is a flaccidity, we cannot do anything or we should not do because that's how the recovers. This idea has to change. We have to move forward. I'll introduce you, if you are already not familiar with this, that I'll introduce you how we understand recovery now. So our understanding of recovery now is that this is the early stage, that is from the first few weeks. If you can see it here, the what in the x-axis it is about days and weeks, and here this is the recovery that takes place. That is in the early stage, in the first few days or weeks is where the maximum recovery takes place. After this is about spontaneous neurological recovery. Okay. And after that, the recovery is actually it's flattening. There is very little recovery that takes place after months, after few months. So this is the area or the duration of time where we can actively intervene and maximize the patient's potential for recovery. Because this is the time, yearly few days and weeks is where maximum recovery is possible. And if patients are spending being inactive, receiving only passive movements and sensory stimulation during this time, this can actually be potentially harmful for recovery. That such treatment might affect or reduce their chances of recovery. So this is what we are working in this webinar. I'm going to talk more about what we can do in these early stages that will maximize the recovery. You can see that it spikes up. So our treatment must be helping to take it up as much as possible within the constraints of the problem that the patient is having. We have seen two reasons. That is, one is for patient shock, fear, and depression during early stages, and also our poor understanding of recovery, where we think early stages is the no activity is normal. And the third point that I want to emphasize, that the factor that contributes to the inactivity is that lack of opportunities for activity, in the sense that most patients during acute stroke, they're admitted in a hospital, or some might even return to home. So the physical environment in the hospitals, it rarely offers any opportunity for them to recover. More than say a patient is usually admitted in a ward, in a general ward, or in a special room where their bed, in general wards their bed, or in the special room, it is that small room becomes their entire environment, and patients are doing most of their activity in the bed itself, which is also encouraged by their family and other caregivers. Unfortunately, because they didn't understand that they're not there, because their intention is to help the patient, but actually their actions are not very helpful for the patient. I don't know if you can see this video. I'm sorry, the picture that I'm having in this slide clearly. That is the picture that I've taken, which the man lying on the bed has had a stroke. He was on third day, and you can see that his wife is actually feeding him in the bed. That he was lying on the bed and it's feeding. She's feeding, and this is a common sight in most of the wards. And this man, even though he had a stroke, he was able to sit on the bed, and he will be able to uh, he is able to sit and eat properly, because during our treatment we make him sit, we make him walk, was able to do that. But unfortunately, that when we are not there, this is how he is spending the time. So family, it's understandable that they want to care for them, but it's because they didn't understand the process of recovery, that there is a very little opportunity exist for them. Then mostly overprotective family is helping them in doing all the work, and everything, including food and of lots of other things, is coming directly to them. So they are just lying on the bed watching TV, and continue in the process of recovery. But this is harmful to them lying on the bed. So this is also one of the reasons that there is a very little opportunities for them to move. Even if they want to move, the physical environment that we have in most hospitals is not conducive for them to move. And in some places, it is also that the hospital administrators or the healthcare professionals advising them not to move. So this is all are contributing for their inactivity. So we have discussed until now that inactivity is a major problem. They spend 90% of the time in inactivity, and there are several factors because of our poor knowledge of recovery and a lack of understanding. Patients are depressed and lack of opportunity. All this is contributing to the inactivity. We've we have discussed this because when we now we are going to discuss the treatment aspects of it, how we can manage this, that our understanding of the problem will help us to develop treatment strategies that are appropriate and effective too. So when it comes to developing treatment, we have to understand this, that what drives recovery. I've identified three factors. There are many factors, but I've identified three factors that I consider the most important. First thing, activity. Second, enriching the environment. Third, family and social support. So when it comes to activity, it is, I don't know if I can say, but that the giving treatment as in the form of activity is still is not a standard practice. It's unfortunate. Again, that's how I see it. That the early stages of physiotherapy treatment in stroke still dominated by passive movement or in electrical stimulation or any other forms of passive modes of treatment. So why this passive form of treatment is dominating is that because most often we think, or we were that's maybe that's how we are educated too, that in early stage there is no recovery, so patient cannot move their limbs. So how do you give activity? And a lot of people have asked me, my students have asked, and whenever I discuss about this to others, I've also asked that how can you give activity in the early stage because patients can't move? Uh, the only answer is that the reverse logic, which is that patient cannot move, and that's why we have to make them move. We have to help them moving. We cannot be saying that they are unable to move, so we will give passive movements. Because as physiotherapists, our job is to make them active, make them regain their skills. And as we already discussed, early stage is the has the maximum potential for recovery. So we have to make them walk and stand and perform activity. The more they're active, the better the outcome is going to be. In the next slides, I will show that how it can be done because I'm sure a lot of people wondering that it is not possible to make them stand or walk or active and so on. But I'll show some example of how it can be done. I'll get back to enriched environment and family and social support as we move through the exercises part. So as far as exercise is concerned, what exercise is, we have to practice functional activities because we have a huge body of evidence suggesting that functional activities, repetitive practice of functional activities is the best available option as far as we have to improve patients' recovery. Right. So what kind of functional activities we can do? That I'm going to I'm showing some examples of it. You can see that two pictures are there, one on the right, another on the left, two different patients. Both of these patients are in the acute stage. The patient that you can see on the left of the screen is 2 days after stroke, and patient on the right side of the screen, you can see she's 1 week after stroke, and both of them are having severe stroke, and they are unable to sit and stand and walk, or mostly they're spending. So what we can do in these stages is to make them stand even with support. even entire support is necessary also we could give. You can see that they were made to stand, and even on the right side if you look at it, the patient was actually leaning entirely on one side, but still she was encouraged and helped to support to stand on the to stand early after stroke. This is possible. This can be done. And whenever I suggest this, the common question that raises is that they are unable to stand. How can we that they are unable to sit? That is, without sitting, how can they stand? Without standing, how can they walk? Or so on and so forth. Uh, Except that our the motor control does not work around that logic. Our nervous system is or the overall motor control is derived by activity. The more you practice functional activity, the better the chances that you might recover it, right? So making them stand or even walk with 2% support, it should be done because that could make them feel more confident, and eventually they are likely to improve more. We have quite a lot of evidence to show that this is helping them out. Another example here, this patient is also in the early stage of stroke, 1 week after stroke, where he cannot even move his fingers or even the shoulders and so on. However, we have given a support. As you can see it here, he was made to eat with support. You can see that therapist is helping them hold a spoon with his fingers because he cannot hold. He was giving support at the wrist, and you can see that he was being given support in the arm also. So the entire activity was performed with support. This is in our college. We must have studied about in the types of exercise. We call this active assisted exercise. So the point is, in early stage, our option is passive exercise, active exercise, assisted exercise. But what I'm proposing here is passive exercise is of no use on it's harmful to recovery. We choose a better option, which is active assisted. And I'm showing these pictures only to impress upon you that this kind of training is feasible, and we have evidence to show that that this helps them in the early stages of recovery. So uh, I'm sure you will, in your setting, you will have different challenges for making them doing this. That you may be the only therapist treating them, and so on. But you can take help from the family and still make them do. This is possible. This is practical, which can be reproduced in other settings too. So, so first part is make them active. Try do active exercises in terms of standing, walking with assistance. Second part is educate them. Most people have their understanding of stroke is like any other illness, that it's a severe illness that they had. So our understanding of illness is that if you fall ill and you have to take rest. That's a simple understanding of the patient's illness, their own understanding. But the point here is we have to educate them as far as post-stroke recovery of illness is concerned, that they have to be active. So you have to educate both patients and the family the importance of activity, and they have to understand. Then only, without the family or patients understanding, without they believe in it, it's very difficult to uh, 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 introduce activity in their day-to-day life. So educate them, explain to them. So the next one, probably the final one, is to enriching the environment. But we already said that in early slides when we are discussing, we said that environment is not offering them enough opportunities to be active. So we have to, as a part of treatment, we have to enrich the environment. When we say enrich, that is making the environment more conducive for activity. Here environment, I mean physical environment, family, and other healthcare professional or supporting staffs too. So how can we make the environment more conducive? I'll show some examples of what we have done in our setting. But I'm sure that you can come up with your own ways of doing things as long as you understand the concept of enriching environment. You can see it here. This is something that we do in our setting, that we brought a thrown dot. We hanged it in the wards and in the ward or in the next room that they have in that hospital, and we ask the patient to use these dots when they are free. It's a form of leisure activity, a game. We found most patients are interested, male, female, most of them. And when we are there, we help them practice with help. And when we are not there, they can even sit over there and practice this. And patients usually spend about 20 to 30 minutes in this kind of activity, and they find it interesting, and they like this kind of activities. So you can also think of some sort of games that they can spend in standing and walk, or even sitting, but that is better than simply lying on the bed. And doing exercise alone throughout the day, it's actually not possible. So we have to come up with some form of leisure activities, an active form of leisure activities, so that they can spend time more actively. Another example here, that this is our version of Scrabble. I'm practicing in Gujarat, so we're in a rural setup, so we didn't actually had the English aspects of version of Scrabble, but we have written Gujarati alphabets in a paper, and we asked the patients to bring everything together, make some words. Here, what he has done is, when we ask him to make a word, he first wrote his name over there. So this is another. This again, the patient is spending in sitting, and is constantly moving, and is constantly thinking. This is we think this will be helpful for recovery when compared to simply lying on the bed. This can also help them change their mood. Another example here, we encourage the patients to uh, read newspaper. We generally ask if they usually do this reading newspaper. If it's part of the routine activity, then we will provide them newspaper from the hospital, ask them to read, so that they can spend another half an hour to 45 minutes sitting and reading in an active form. And there may be cases in which patients don't have a routine of reading newspaper, but there are one instances we actually asked another patient. They said, I don't read newspaper. Then his wife said that he used to read religious textbooks, uh, uh, some other form of religious versions, and so on. So we asked them to bring that book from their house, and we told him that he can spend time reading that book. So we thought that's again another active forms of hobby, so that he can spend more time on sitting and uh, doing something active. So next is, other than these leisure activities, we should be creating opportunities for socialization. We know that most often they just lie on the bed, and they've had a life before they meet people, they talk, but here they are left with their fellow patients and doctors and so on. So their socialization is entirely affected. So what we could do is to create opportunity for socialization. We can do a lot of things. You can take them out and make them sit in places where there's a group of people are sitting, and so that they can have a chat. In our case, we took them to a nearby temple over there, just opposite to the hospital. So we take them to the temple, and this particular patient over here, that we every day we help them to go to temple, and she spends about 45 minutes over there, and then she come back by with walking with the help of 2 3 people. So this is again another form of socialization that we thought of, but based upon our patient's need, we can try that. I think most of the hospitals are having similar places, maybe the cafeteria, or even temples are there in most of his hospitals. So we can take them, or we can encourage their family to take them over there, and then spend some time. Again, that is likely to promote recovery rather than simply lying on the bed. Next, Family's participation. This is fundamental. Without the participation of family, our process of rehabilitation will not be successful, or the success will be very much affected if they don't participate. See, in this case, what in the picture what you have here is actually a patient that we treated, and when we told educated him about recovery and activity and so on, and we helped him make a stand, a lot of things that we have tried, but he has refused to do anything. And then we talked with his wife and asked whether he will listen to anybody else, and his wife said that only to my son that he will listen and nobody else. So what we did in this case is we called him, his son, and asked him to come here and come to the hospital, and then we told him that this is what we wanted, and if you could help him and uh, understand and so on, and it will help. So what he did was, it was a little surprising that the moment his son has come, he felt very happy. And when he asked him, okay, let's go for a walk, I'll help you out. When he said, he has immediately agreed and he has started walking, something that he was not doing before. So the participation of family is very, very important. And we have to, because as physiotherapists, we are going to spend about 30 to 45 minutes with the patient, and mostly their family is with them. So unless we help them, unless we involve patient into their daily activities or helping, then it becomes uh, difficult to make them active. So families participation early stage, it's very essential. Okay, so we have come to the end of this webinar. In another 2 minutes, I'm likely to finish it. Right. So we have discussed until now what's the problem and what we should do. And this slide I kept specifically. I'm going to re-emphasize what we discussed during the early slides on recovery. That what we should not do is giving passive exercises. Passive exercise, I mean passive movements and electrical stimulation, any forms of treatment that doesn't involve active participation from the patient. Why is this? Because as I told before, early stage is the time where maximum recovery takes place, and we cannot be giving passive movement. Again, this has got a lot to do with our understanding of recovery, because we think that early stage is all about flaccidity, and passive exercise is the only thing that we can do in the early stage and wait for the recovery to come, and then you can integrate functional activities later. But this idea, as we have already discussed, is completely outdated, and our present understanding of recovery is that the more the activity and more functional the exercises, the better recovery is going to be. So passive movements is harmful for recovery. So we should restrain ourselves from giving that. Okay, so this the another one that we are issues that we discussed early, that when to start exercises. We have huge amount of evidence says that as early as possible, 2 to 3 days post stroke should be right time, or you can even start before that. There are studies in which they've started even on the 24 within 24 hours of stroke and so on. But let us not get into how many days, but the point is as early as possible. It can be as early as 1 or 2 days after stroke, because again the same point, earlier stage, acute stage, is where maximum potential for recovery. So we have to start early, and we have enough evidence to show that early activity and more activity is helpful for patients' recovery. So, of course, until now I've spoke about activity, and activity. And there are one caveat that I want to add, where you may not be able to do all that thing I've suggested, is the unstable vitals. If the patient is having frequent variations in their BP or other vital signs, temperature, pulse, and so on, that time we may not be able to do this. It's very small group of patients who still have this problem, which is considered a sort of emergency. So we will not implement these strategies in patients who are having unstable vital signs, and also patients who are having severe cognitive impairments, attention, orientation, these problems, and so on, severe problems. Okay, so we have come to the end of this webinar. I'm summarizing what we have learned. That is what is happening, why our patients are not moving, shock, fear, and depression, poor knowledge about the stroke, influenced by brainstorm stages of recovery, and lack of opportunities for activity. Both the family and physical environment is not providing enough opportunities for activity. And what we should do, educate the patients, start functional exercises early, and establish a daily routine for them so that they will do it repeatedly, this activity, and create opportunities for socialization. We have discussed taking them out and so on, and encourage active forms of leisure activity, some games or anything that you can think of which would be feasible in our setting. Okay, everyone, thanks for listening. If you are having any doubts, you can mail to us. We will send this PowerPoint to everyone who has registered for this. And if you're having any feedback, you can type on the comments and we will be looking into it. Thank you, everyone. Thanks for listening.